Hi, everyone. I'm Enrico Asher, Executive Director of the Frank J. Veith Society. This webinar is all about the second annual Innovation Award sponsored by this society. This year, the competition was even more robust than last year. 30% more abstracts submitted and many with patent pending, reflecting truly original work in the vascular space. This led us to ask the authors who did not make the cut this year to resubmit their abstracts next year. They are truly excellent. It's important to emphasize that the abstract selection process was blinded and the selection of judges reflected expertise in different areas of vascular surgery. Allow me a moment to recognize by name the judges who participated in this project. Thank you, Dr. Zhong Shen, Jean-Pierre Beckerman, Ignacio Scotto, Nelson De Lucia, Anil Hingarani, Michael Marin, Ken Oriel, Juan Parodi, Janet Powell, Jorge Ulloa, and Wayne Zhang. All of us at the executive committee are indebted to you for your commitment to this award. For those who could not attend this webinar, we will post it in its entirety this afternoon at www.veithsymposium.org. Needless to say, it's a real pleasure to have Dr. Veith preside over this webinar. This society was created by many internationally recognized vascular surgeons who trained under Frank Veith to honor his legacy to vascular surgery. Frank, please make your introductory comments. Thank you.
Yeah, thank you, Enrico. This, to me, is the most exciting webinar of all the excellent webinars that Enrico Asher and Peter Glavitsky have created. And this is because this webinar deals with what is new and innovative in vascular disease management. So I applaud Enrico and Peter for putting this exciting webinar together. And I congratulate the winners, the honorable mentions or runners up, and all who took part by submitting their excellent abstracts. You are indeed the future in the treatment of all vascular diseases. So I greatly look forward to your presentations today, and I congratulate all who are taking part. Dr. Glavitsky, I believe you're going to introduce the first presentation. Peter?
Yes. Thank you. Just one second. Thank you very much, Frank. I'm just going to introduce Peter quickly. It is my pleasure to introduce Dr. Peter Glavitsky, the moderator for this webinar and president of this society. If you don't know Peter, you probably tuned into the wrong webinar. He's known all over the world by everyone. Dr. Glavitsky is the Emeritus Chief of Vascular Surgery at the famous Mayo Clinic, and I'm privileged to share the moderation of this webinar with him. Peter, please.
Good afternoon, everyone. Thank you, Frank and Enrico, for the introduction. It's a real honor to serve this year as president of this distinguished society named after Dr. Frank Veith. Bill Gates once said that innovation is the most powerful force to change the world. So we are indeed excited that we are able to give out this year the second time awards for innovations in vascular surgery. And we are going to start right away with one of the winners, Rumi Fazer, Associate Professor of Vascular Surgery at the University of Minnesota. And Dr. Fazer's presentation is on double-walled aortic stent graft for restoration of aortic compliance. Dr. Fazer? You might be muted.
Yeah, Rumi, we cannot hear you.
Thank you. Can you hear me now?
Yes.
Wonderful. Phew. I would first really like to thank Dr. Veith, Dr. Glavitsky, Dr. Asher for putting together this opportunity to present innovations in vascular surgery. I'd obviously like to thank the judges for choosing ours to get to showcase. Again, all right, I'm a co-inventor for this device, but beyond that, I have no financial disclosures. The aorta in health is not just a conduit. It is a moderator of pulse pressure through its elasticity and compliance. In fact, 65% of the capacitance of the arterial tree is handled by the aorta, and this allows it to protect vessels and organs from the heart to the kidneys and brain from pressure injury. It decreases afterload, and it decreases pulsatile injury. With aging, however, the aorta lengthens and dilates, as we all know, but it also stiffens. And as it stiffens, it loses its elasticity and its capacitance, and therefore its ability to protect organs. The way we measure aortic stiffness is by a parameter called pulse wave velocity. Aortic stiffness is actually a precursor to systolic hypertension. It is also an independent risk factor for cardiovascular death with a relative risk of 2.7-fold. Treatments for aortic stiffness really do not undo the stiffness. They compensate for it through other mechanisms. Aortic stiffness is also, as we vascular surgeons know, part of aortic aneurysm disease and aortic dissection. And our treatments often for these processes involve using a stent graft, which, although they prevent rupture, cause stiffening and worsen the problem of aortic loss of capacitance. Aortic stent grafts are now shown to be detrimental to cardiovascular health and aortic stiffness through multiple studies. But clinically, we don't see this. In fact, we know stent grafts help people. How is this possible? Well, because there's compensatory mechanisms. The peripheral vasodilation, to speak of one, but also medications that we give these patients in this patient population, which are fantastic. And lastly, to be honest, we expect this patient population to die from something, and we don't always connect the dots. So now that we know this, aren't there simple answers? What about just a more elastic stent graft? Well, if you put a more elastic stent graft in a rigid aorta, it has nowhere to go. So just making a more elastic stent graft will not solve our problem. Well, what about if we did that, but we made the stent graft a little smaller in the middle? Huh? How about that? Then it's got a place to go. Unfortunately, there's no such thing as an empty space in the aorta. That space will fill with blood, that blood will clot, and that will essentially be incompressible. How about we give up on this whole idea of a stent graft after all? You know we can do a nice, beautiful open repair, and when we leave the OR, we will see that pulse beautifully. Unfortunately, we all hope and expect that aortic repair to become incorporated, and that means to scar, and when it scars, it will no longer have that elasticity. So this brings up our technology. The outer wall is just like existing devices, a rigid stent graft. But then there's an inner thin elastic membrane. And between the two, we fill the space with a biocompatible gas. And because it's a gas, it is compressible. And so as the heart contracts, the reservoir can be compressed. And when the heart relaxes, it can re-expand. We've done some basic work to this point, mathematical modeling and bench flow loop work, and that has gained us a provisional patent. Here's some basic mathematical modeling. This is the native aorta pressure. If we add a rigid stent graft, that pressure increases. With our device, we've been able to show that we can significantly lower that pressure. By definition, our device will have a smaller lumen than an existing stent graft, but we've shown that we can get to quite small lumens before we start to affect resistance. In a bench flow loop study where we've created different types of models of the aorta and inserted a stent graft, the most basic of which was just using gas from bubble wrap inside a stent graft, we've been able to show that with a healthy model of the aorta, where pulse wave velocities are here, the rigid stent graft increases things, but we can bring them back down to almost the same pulse wave velocities. And if we start with a rigid aorta model, we can actually lower pulse wave velocity by almost 5 points. So the low-hanging fruit target for this technology is, of course, aortic dissection. If we can restore capacitance in aortic dissection, we can heal the disease. It also may have a role in patients who have a AAA but more advanced vascular disease, where that further stiffening of the aorta may be problematic. But I really think we should be aiming higher. Treat patients with severe systolic hypertension. A reduction in pulse wave velocity of 2 to 3 meters per second is very achievable. And I want people to understand that each 1 meter per second increase in pulse wave velocity is associated with a 15% increase in cardiovascular and all-cause mortality and morbidity. The same thing can be said for systolic hypertension. If we can just reduce that by 10 points, dramatic results in vascular disease can occur. So in conclusion, all vascular surgeons, as vascular surgeons, aortic health is within our wheelhouse. This is our problem to take care of. We need to be aware of the aorta's role in vascular health. Restoring aortic health may be the highest impact contribution we can work towards. And the double wall stent graft is one idea, but we need others. Cape of Good Hope that I hope we're rounding, guys. And I want to make it clear, I am a vascular surgeon and I'm very proud of this little idea, but it would have stayed a silly little idea if not for the fantastic engineers who I get to work with on a regular basis at the University of Minnesota. Thank you. Oops.
Thank you very much, Dr. Fischer. This was an excellent presentation. And who else is going to discuss this first? And one of the greatest inventors in vascular surgery, Professor Juan Parodi from Buenos Aires, Argentina.
Yeah, I think I know something wrong here. Can you hear me?
Yes.
Yes, we can hear you very well.
I think it was a great presentation. You know, all the initial considerations are well known. Everybody knows that what we are doing prolongs the life of the patient, but we have seen patients, mostly patients treated when they were very young with transections, that they develop cardiac insufficiency and uncontrollable hypertension. So we reviewed 100 of patients, and I agree 100% with your conclusions that hypertension, the increase in systolic pressure, you drop the diastolic pressure, and that produces diastolic dysfunction and cardiac insufficiency and increase in vascular diseases. And also the flow in the coronary arteries in diastole is decreased. And we had 5 patients with angina with a normal coronary arteries because the diastolic pressure was very, very low. So we agree 100% with your considerations. There are many ways to deal with this. I think what you are doing is one of the ways, and apparently is very effective. I have a couple of questions. We have done many years ago a study about the increase in systolic and decrease in diastolic diameters. And we learned that the aorta is never circular, it's always ovoid. So we made all the calculations with circumference and then getting the diastole from the circumference. But the question I have, your idea is one of the many ideas you could have to increase the elasticity. The first question is how much you change the diameter in systole and diastole. And secondly, using carbon dioxide, aren't you concerned about the diffusion of the carbon dioxide? And the third is, have you done studies about material fatigue in the long term with this? I think it's a great idea. I think many people are now trying to solve this problem. Your idea, I think, is very good, but the questions are, how much you increase you change the diameter, in systole and diastole? Aren't you concerned about the diffusion of the carbon dioxide? And have you done any material fatigue studies in long term?
Thank you, Dr. Prodi. First, I want to say thanks for someone with your stature to validate that these problems occur. I think is critical. I think while experts in the field are fully aware of this, we are not attacking it as aggressively as we should. Your questions about our technology are completely valid. Let me start with the simple one, carbon dioxide. I think this is obviously a biocompatible gas, but it is not the final gas that we'll likely use in a final technology, because I do agree, it's a small molecule that is very hard to keep trapped long-term. If we had to go that route, we would have to come up with a strategy where we could refill this. And I think that's more challenging. So fortunately, there are patented gases that seem to fill this role. But right now, our technology is still early along, or too far in its infancy to get to that point. Same with your question about material fatigue. We do need something that can pulse with the aorta for as long as the patient is around. And we have not come anywhere near that. Our modeling, though, can perhaps answer your last question, which is about how much we can narrow the aorta with our flow lumen. And we can get down to about a little less than 1.5 centimeters. Our current work, one part of it is creating a flow loop that has a cadaveric elderly aorta. So we've been doing this work so we can insert stent grafts in this. The other part of that work is trying to model what the ideal shape of this gas reservoir should look like. And it's looking more and more like it should be sort of an inverted teardrop shape. And that way you can increase the amount of impact without narrowing the flow lumen too much. But this is all work that we're in process of doing, Dr. Parodi. Thank you again.
Thank you very much.
I'm sorry, the last comment. I think what you said at the last part of your presentation is very, very important. We see all patients over 85 or 90 with very rigid and calcified aortas with uncontrollable hypertension. And those patients have dilated aortas. So this idea can be used that we are doing the same thing you are doing in patients with hypertension. And because you decrease the diameter that is already dilated, and at the same time, you can increase the elasticity. And those patients are very hard to be treated with drugs because everything is very rigid. Even the small arteries are very hypertrophic muscle. So I think to treat hypertension, this would be another way to use this kind of new ideas. Thank you.
Thank you.
Thank you very much, Juan. Professor Janet Powell joined us from London, and I think, Janet, you have a short time for one burning question.
Yes. Would the likely morbidity of this device exceed the already high morbidity of patients with systolic hypertension, particularly when you have the alternative of renal denervation?
Dr. Fazer? It looks like we lost him.
You got so many questions from Dr. Parodi, he went to take a break.
His speech.
All right, so we're gonna go. Oh, here it is. Rumi, did you hear the question from Professor Powell? No, I think there's a picture only. He's not there.
Yeah. Well, I think he's going to answer it at the end. Do you want to proceed, Enrico?
Yes, we are ecstatic to introduce Professor Wei Guo, who is the Chief and Professor of Vascular and Endovascular Surgery at the General Hospital PLA in Beijing, China. He's also the Vice President of the Chinese Vascular Society. And just on the side, he was one of the persons of the 4 people that won the honorable mention last year. So now he won the big award. And we expect him to come every year with some new innovations. So Professor Gu is going to talk to us today about his new device. And not only that, but also the safety and efficacy of the G-branch endograft for the treatment of thoracoabdominal, pararenal, and justarenal aortic aneurysms. Professor Gu, please.
Okay, thank you, Enrico, Dr. Frank, Dr. King Oil, Dr. Glowacki, and Dr. John, and every expert. Good afternoon. And a great honor for me to weigh. Sorry, I share my screen. Can you see my slides?
Not yet. Yes,
Okay.
it's good now.
Okay.
Yes.
A great honor for me to win the Frank Veith Innovation Award again. My pleasure to introduce our works about the G-branch endograft for thoracoabdominal and aortic pathology. This is my disclosure. We know a great challenge of endovascular repair, not only from thoracoabdominal, but from the jugular parietal way, and especially some patients with the lessons terrible angulation, not only from proximal and distal. So we rarely need off-the-shelf wider indications of these devices. We try to develop off-the-shelf mixed with multiple branches in branch. G-branch contain double inner branch and combined with the double outer branch at the almost the same level, and proluding wire through the double inner branch and semi-release design. Because of the each stem only 7.5 millimeter in length and 2.5 millimeter gap between stems. So this design concept makes the G branch has favorable flexibility. The inner branch is still unobstructed when the stem is large bending. And coverage, the bridge cover stem is unique interwoven Nightingale wire sandwiched by EPDLV, providing favorable flexibility and fracture resistance. Because of the different diameter of proximal, distal, and the double inner branch and the different upper part lengths. So a total of the 26 types of the G branch endograft are available for use. Why different diameter? Different proximal diameter makes the endograft matching aortic diameter easily. And the different distal diameter makes renal artery concentration possible, especially in type 5 TAAA, perennial, jugular, even short neck AAA with terrible angulation. You know, terrible angulation, we can't use fellation. We can't use the multiple parallel technique. Why different lengths? The proximal main body with the 50 or 40 millimeter in length is more suitable for patients with extent type 4 TAAA, perennial, or jugular AAA. And a proximal main body with 70 millimeter in length is more suitable for patients with extent 1, 2, 3, and 5 TAAA who need extensive thoracic aorta coverage or more proximal coverage second stage in future. Why mixed design? We know all outer branch design theoretically leaves a large visceral aortic lumen, and all inner branch design should require 4 preloaded guide wire, which may significantly increase the profile of delivery system. Especially very important factor, angulated aneurysm may be adverse to the regular construction of inner branches. And for infrarenal abdominal aorta with small size, inner branch design may occupy too much nominal space. Why serial flow branch cover stem? From number 2 cases of the first image study, we can see cervical trunk compressed by ligament. But after operation, 36 months, 1 year later, follow-up CT, we can see the cervical trunk landing zone diameter was getting bigger because of cerebral flow has enough radial force. And we are investigating every case, every branch vessel distal landing zone diameter changes after operation. About the G branch procedure, it's very clear. Firstly, inner graft in advancement and precise positioning. Keep double inner branch, anterior aorta and above cervical trunk, and then to gain branchial femoral access. Cervical trunk SMA catheterization, bilateral renal artery calculations, and then last step, distal stent graft extension combined with bifurcated stent graft or straight stent graft. We have finished our first in-main study from October 2019 to March 2021. A total of 15 patients enrolled in film study, including the TAAA, pruritus, and jugular tube. This slide showed every case or 3D construction after operation. And 12 months follow-up results indicate low endoleak, no paraplegia, low branch occlusion. One patient died of acute cerebral infarction at post-operative 10 months. And depending on this small cohort experience, we began to organize our prospective multi-center guarantee study. And this study protocol has been published on BMJ Open and planned to synthesize 73 cases. Because of the COVID-19, guarantee study is going slowly. From November 2021 to May 2022, 23 cases were enrolled in this study, and over 50% cases with type 4 and jugular or parietal AAA. Right side, the first 21 cases follow-up CT data. And about the procedure surgery result, we can see the average operating time 270 minutes, contrast 180. No branch artery stenosis, no paraplegia, no patient died, but there was one patient with type 1 endoleak, and technical success rate 96%. So in conclusion, G branch seems to be suitable for varieties of aneurysm with challenging anatomy, effective and safe treatment option for TAAA and complicated AAA, lower rate of type 1A endoleak attributed to enough proper landing, and optimized bradycardial stent design, and G branch allows either proximal or distal stent graft extension. But some limitations from indispensable for axillary or branchial artery approach. Utilization for pathologists with lateral lumen at the renal level remains of concern. Thanks for your attention.
Thank you very much. Very nice presentation, and congratulations for winning the award and sharing with Dr. Fazer. We're going to call our invite discussants, Dr. Wayne Zhang, please, for his burning question.
Thank you, Enrico. Thank you, Dr. Veith, Dr. Glowacki. Dr. Guo, congratulations again for winning this very competitive innovation award. I really enjoyed your presentation. Your branch TVAR graft is a true great creative and a novel device. And most importantly, it has been approved to be safe and effective with your excellent preliminary results. I do have two questions for you because of the time limitation, so I have more, but Enrico only asked me to kind of just have two questions. So the first one is, what are the advantages of your stent graft compared with the others? For example, Cook branch graft and Gore branch graft. So the second question is, you also presented your cases, with excellent slides. So you deploy the stent graft actually higher. The renal artery branch actually is fairly long. And then we know that, and some cases are very angulated at the renal level. Do you, have you seen any like a sharp angulation at turn or like significant tortured? Maybe we call not the neck, it's because it's thoracoabdominal. But if you have any sharp angle into the renal orifice, and you worry about the long-term patency about this, that's kind of my two questions, Dr. Guo. Thanks.
Thank you, Dr. Zhang. Very perfect question, I think. The first question is about how about advantages of this T branch compare the Cook T branch and Gore Tan-B stem graft. We know Cook T branch and Gore Tan-B stem graft also are very perfect stem graft for thoracic-abdominal aortic aneurysm. But compare Cook T branch and the Gore Tan-B G branch, a different diameter design and different length design. We have more types of G branch. 26 types G branch can be used for the patient. And another advantage, I think, because of the G branch designs, every stent is very short, so excellent flexibility makes this G branch can be used in a turbo angulation, thoracic-abdominal or jactrenal or pararenal AAA. And about the second question is about the renal artery patency, right?
Yeah, that's correct.
Yeah. I think the renal artery patency not only related with the graft, the branch graft bridge stance length, but also related with the space of the aorta and the distal landing zone of the target vessel diameter. So when we are enroll patient, the first thing is we should exclude the target vessel renal artery very small, very calcific, or tightly stenosis patient. And then we must consider about the space of the aorta, especially the gap between the distal stent graft main body and the vessel wall, the cavity. The space, enough space is very important from the bridge stent. So our film study result and in our multiple center study and current result, we didn't find any renal artery occluded. Of course, we did a longer time follow-up, I think.
Great, thank you.
Thank you. We're gonna just ask for Dr. Peter Klavitsky if he has a quick question because you're very late on our time.
I just have one question other than I congratulate Dr. Guo for this excellent invention and presentation. I am also worried about the renal arteries and maybe a narrow aorta at that level. What % of the patients with juxtarenal aneurysm or pararenal aneurysms were not candidates for this procedure when you selected your first 15 patients?
Thank you, Dr. Glowacki. At the current stage, only a few cases in our clinical study, so no detailed data about how about the percentage of the jactrenal pararenal tube can be treated by G branch, I think. But from our one center experience, I think over 70% jactrenal and pararenal and TAA can be treated, even if the lessons with a turbo angulation, proximal and distal angulation we can are fixed by G branch. But the branch vessel quality is very important. Not only renal artery, but celiac tract and SMA. In Asian patients, some Asian patients with small aorta a small visceral artery and renal artery. So I think this kind of patient is not the indication for deep branch device.
Thank you very much. We are going to proceed now with the honorable mentions. And the very first one is Dr. Noemi Bala from Barcelona, Spain. And Dr. Bala and her co-authors are going to talk about development of a bioresorbable patch to treat aortic dissections. Dr. Bala?
Thank you very much. Are you seeing my screen?
Yes.
Okay, so thank you for the opportunity to giving me the opportunity to present today. I'm very honored to present my work and of my co-workers. I have no disclosures. Aortic dissection is one of the most catastrophic events that can occur in the aorta and represents a major challenge in the cardiovascular field. Current standard of care inherited from aortic aneurysm treatment presents significant clinical limitations that lead to mid and long-term complications. Focusing only in the endovascular repair, eligibility remains low due to the geometrical and mechanical mismatch between the graft and the pulsating aorta. To overcome current limitations, the endovascular procedures but taking advantage of its benefits, we have developed a biomimetic adhesive patch to treat aortic dissections. It is geometrically more respectful with the native aorta and has the same mechanical properties than healthy arteries. It is attached to the aorta with a very strong biocompatible vascular adhesive. And all of this is thanks to the unique microstructure that we have created. It consists of a two-side matrix. The luminal side having fibers aligned with the bloodstream to promote endothelial cells migration. On the contrary, the abluminal side has its fibers randomly distributed to promote smooth muscle cells recolonization and to provide the patch with the desired mechanical properties. We have invented and patented this disruptive device. We have designed the entire system, including the catheter, the deployer, the patch, and its adhesive. The catheter navigates through the aorta and bends at the entry tear. Then the deployer deploys the patch, which is adhered against the aorta. The patch plugs the leak, empties the false lumen, and initiates the local tissue regeneration. We have already demonstrated in animals and in the lab that our solution can work. We have performed several animal studies at different time points, from acute studies to prove adhesion in 30 minutes test, to chronic studies of 30 and 90 days to evaluate the tissue response. We are now about to finish our latest study in which we have created intima medial damage before implanting the patch to mimic a dissection. This study aims to evaluate the different tissue response when an injury is present in the aortic wall. The implantations are performed via an open surgery where the aorta is exposed and cross-clamped cranially and caudally. Once the blood flow is stopped, an incision in the upper part exposes the lumen. The adhesive is then distributed over the patch and the patch is implanted in the desired site. After the implantation protocol, the deployer is released and the incision is sutured. A vascular echography is performed right after restoring the blood flow to visualize the patch and ensure its proper adhesion. Tissue integration is visualized during the test using TE, and as you can see in the images, the integration of the patch is clear over time. And at 90 days, you can see that the patch is very distinguishable from the tissue. The histology results in the chronic test confirm the integration of the patch within the tissue with very low inflammatory response. And as seen in the slides, the patch is completely covered by cells at 30 days. And if we move forward to the 90 days results, those are spectacular. We have observed how the cells over the patch are more mature than in the previous test, while the inflammatory response remains very low, along with null thrombogenicity. We also observe global reendotelization, neointima formation, and, surprising even for us, neovascularization. So recently, we have decided to go one step further, creating an intima medial tear using a surgical blade, mimicking dissection. The tear is first expanded with a nerve hook, and then the aorta incision is sutured. The flow is restored, and the progression of the dissection is monitored using vascular echo. The aorta is reclamped, and the tear is covered with our patch. I'm sorry, but we will share the results of our latest experiments in the next Veith meeting in November. So I would like to tell you that you have to stay tuned. Sorry.
Are you done?
Yes,
Thank
I'm
you.
trying to stop sharing. I have stopped sharing, right? Yes.
Yes. Thank you very much. The burning question will come from Professor Nelson Del Lucia. I hope I pronounced his name correctly, from Sao Paulo.
Oh, thank you, Dr. Glavitsky. Thank you, Enrico. Congratulations, Dr. Bala. Very interesting development. And well, it's still in the animal model stage, I suppose. And my question is, how do you think in a human model, when we have several holes after an aortic dissection and sometimes a very narrow lumen, a true lumen, how you think you could actually use your device and eventually by means of IVUS and or when you have to restore the lumen by a bare stent or by a regular prosthesis, how you think you could still use this device to close the actual hole and creating the false lumen? It's that's my concern.
Thank you for the question, Nelson. So the thing is that we are planning to expand a little bit the true lumen by first introducing a mock device to keep enlarge the artery, and then we will place the patch in a second shot. The thing is that we are designing the catheter to gain a little bit of a free space in the case that we have these narrow aortas. So we will have two different bending radius, one that will go to the other side, and then we will bend the catheter towards the artery. So we are now performing tests in cadavers to investigate all these different aspects with the narrow aortas, but I am sure that we will solve this problem.
Okay. Thank you, colleagues, and I'm done. Thank you.
Thank you.
Well, our next speaker is Dr. Tomas Baltrunas. He's the founder of the UAB Innovative Medicina in University of Vilnius in Lithuania. And he's going to talk to us about the first experience with endovascular robot Sentanti. Dr. Baltrunas, please.
Hello, everyone. It's a big honor and pleasure to participate in this symposium and to be mentioned among these outstanding innovations. So I'm Tomas Baltrunas, I'm a vascular surgeon, and I would like to present the first experience with endovascular robot Sentanti. So I do have conflicts of interest. I'm the founder and shareholder of Innovative Medicina, and we are using robots in very many aspects of our life, also in operating rooms. However, endovascular procedures are performed exactly the same way as it was 40 years ago, when the doctor is standing next to the X-ray source and partially protecting himself with heavy lead aprons. So do we have endovascular robots? Actually, yes, we do. However, they do not solve any problems. So both currently existing endovascular robots, it's CorePath and RoboCath, are actually manipulators of one thin guide wire. So that is why they are certified for robotic assisted procedures only. And That is why only part of the procedure can be performed robotically. So what is a typical workflow? So the doctor has to start the procedure manually, and only then he can attach the robot and play with the joysticks. In real life, usually one of the team has to stay near the robot, and at the end of the procedure, the doctor has to finish the procedure manually again to retract the guiding catheter and to finish the procedure. So 5 years ago, we have come to a totally new idea of creating a radically new approach of endovascular robot, which can perform the whole procedure robotically, from the very beginning to the very end. So we have spent 40 years with the technical development, different versions of the robot, and we have spent hours of bench testing and decided not to go with the joysticks and with the gamepads, but just to mimic exactly the same procedure as if standing near the operating table. And we have spent hours also in a cath lab with an animal testing. And at the end, we have created Sentante. So Sentante can perform the whole procedure robotically. Sentante is compatible with all standards endovascular instruments out of the shelf, so no dedicated instruments are needed. The whole range of guide wires are accepted. So all catheters up to 8th French are compatible with the Sentante. And the most important thing is that Sentante can manipulate 3 endovascular instruments at a time at full their length. So you can exchange guiding catheter, or you can leave the wire, or you can change the stent. So this all features actually allows the future possibilities of teleprocedures, telesurgery. So another features is interface. So we are using the similar guide wire and similar catheter to one which are inserted into the patient. So if the wire resists to talk in the patient, the doctor can feel it with his fingers in the cockpit. So this is the crucial, let's say, solution in the robotics to have a haptic feedback. So on the right side of screen, you can see the procedures performed exceptionally with our robot without any assistance of human being on site near the operating table. So over the wire, and then you will see monorail stents are implanted. So 2 years ago, we have been approved for our first in vivo trial, and primary endpoints were technical success and safety endpoint, and secondary endpoints were users' opinion regarding haptic feedback. So we have tested 3 different wires, ranging from very floppy 014 Terumo run-through and ending up with 035 Cook-Lunderquist wire. So 3 doctors of different specialties tested, and each of them had to reach 19 target arteries. And the results, so technical success rate was 100%, 0 of vessels were injured, and secondary endpoints, so the Sentante technology exceeded the expectations, and haptic feedback was evaluated as 4 out of 5. So there you can see embolization procedure, and actually it is Sentante the only robot which can perform endovascular embolization robotically. This is microparticle implantation, and the disadvantages of the robot is that you have to use a little bit longer instruments because of the dead space. So if you usually use, let's say, 80 centimeters, with a robot, you have to choose catheters of 1 meter length. There you can see embolization with the coils. So for the future, we do see a good possibility also, in addition to doing operations, to have a realistic training platform. In the further future, it could be an AI-based automation for some of the procedures or part of the procedures. And I think more or less that's it. Thank you. I cannot share you any real photos, but those who are interested and those who are attending LINC in 1 week, in 10 days, so can connect me via email, and I can let you play with our robot in real life. Thank you for attention.
Thank you very much, Dr. Botrunas. Really very, very exciting stuff, and it looks like it's working well. I would like to invite Dr. Ken Oriel, the co-chairman of the Veith Symposium, for his comments. Ken, please.
Thanks, Enrico and Tomas. Congratulations, very, very cool. And I have just a couple of comments and then one burning question. And the comments are, it's really nice to see something that is not done with joysticks, but done with the same techniques that surgeons, cardiologists, radiologists have been using for 40, 50 years. You don't have to learn something different. And I know this takes a lot of effort and a lot of money to develop something like this. So again, great job. My one question relates to how do you get this into the hands of clinicians? What is the regulatory pathway? Forget US, but just in Europe, how do you go from where you are, which great results in animals, how do you get that approved for use in humans?
So thank you for your kind feedback and for the question. So actually in the Europe currently, it's not actually easier to get approval using new MDR regulatory. So, but because we are based in Europe, so we will start with MDR directive and go for approval. Technically, it will be, as for CE mark, it will be a class 2B instrument as all other endovascular robots. So we are not leaving anything inside the body, and we are not manipulating inside the body. We are just manipulating the standard instruments which are dedicated for performing the procedure. So it's class 2B. So human test will be needed, and actually we have a bunch of clinical sites which are interested in participating in clinical trials. But of course, those who are from United States are also invited, and we are very welcome if you have that initiative. So we will come to USA. So in Europe, we will be CE marked in 2024, and in a couple of years in United States.
Well, when you train the European investigators, they can do the cases in the US, right? Because you don't have to be close to the patient.
Right.
Thanks.
Thank you. Dr. Levitsky.
I cannot hear you. You're muted.
You're muted, Peter. You're muted.
Sorry, I am so sorry. Thomas, that was an exciting presentation. Congratulations. The next award, honorary mention, goes to Professor Marian Brodmann. And Professor Brodmann is the head of Division of Angiology at the Medical University of Graz, Austria. And the title of her presentation is the Temporary Spur Stent System for treatment of infrapopliteal arterial disease. Dr. Brodmann?
Yes, thank you. Can you hear me and see my screen? Yes, I see Enrico noting. So thank you very much for inviting me. It's a big honor to be here and to present the temporary spur stent system for treatment of infrapopliteal artery disease. And this is a new technology, which is a stent based system, which should help us to do a better vessel prep. And I think this is very important, especially in the below the knee arteries, where we have these issues with regard to vessel recall. We have, this high degree of calcification. We have this long lesion lengths. We have these lesions who are showed tortuosity. And when we are not doing an ideal vessel prep, we end up with dissections, and that brings up into real troubles. And the other thing is, we need to ensure in any vessel area the drug uptake in the peripheral space. And one thing with regard to suboptimal drug uptake is the diameter mismatch, that we don't have an adequate luminal surface contact, and for sure the uptake then at the end and the penetration. So with regard to this temporary burst and system, I just want to show how it works. It's a 6-French compatible hydrophilic coated delivery system. It's very simple. It's a familiar delivery system like any stent. The only difference is that you can retract it and bring it back and therefore bring it out of the vessel. It's a self-expanding temporary nitinol stent. We have right now 3 and 4 millimeter in diameter. It's able to treat short and long lesions, and this spur creates channels for greater drug uptake when followed by a DCP. It's a temporary mechanical scaffolding, and this should really reduce vessel recoil. So the intention is to create stent-like results while leaving nothing behind. So it's deployable and retrievable. It's a controlled penetration and reduces vessel recoil. There are some trials out there, especially with regard to different drug uptakes. We have the deep out of yes trial where we test paclitaxel, and here in Graz, where we do our single center study, we test the limus uptake, if this could be improved by this burst-in system. We know that there is an issue with regard to these different drugs, and there's also this still this discussion about the concern for long-term impact of paclitaxel. So this is how it works. I just show an animation video. So we cross the lesion and assess the stenotic site or the lesion site. We then pre-dilate the stenosed area with a just Bober catheter, then bring it out, and then bring back in the spur stent system to the side where we want to have this better penetration of the vessel, see how it works. We then can, at the end, fully retract and bring it out of the vessel at the end. And this is really feasible. It's easy to do, and really also allows, when it is expanded, fully blood flow. So there is no fear that at the end of the day, when you have the spur stent inflated, that there might be clots who should occur. With regard to clinical validation, I already told you, we have some trials ongoing. The TIPA trial was a prospective single center study, the feasibility study with good primary efficacy, primary patency at 6 months, 88.9%, dispersed and plus dilutonics TCP, really enormous and high safety profile of 100% primary safety at 3 days, and freedom from target limb major amputation, clinical driven DLR for 6 months, 94.1%. The TIPA out of yes study, it's a prospective multi-center study in Europe and New Zealand, 106 patients. They just have completed the enrollment. And there's also a vessel recoil sub-study just showing, trying to show that the vessel recoil might be reduced with this spur stent system. And we are doing the prospective single center study here in Graz, Austria, with a limus coated TCP with the same endpoints as TIPA out of yes. So this we have in the meantime included 23 patients. The mean age is 73, so mainly diabetics. Around 40% of patients with females, and you see that the risk factors of these patients are really the ones with critical limb ischemia, especially chronic kidney disease. So we have, with regard to the lesion characteristics, 35% of patients who had total occlusion, and the spur stent treated length was a mean of 97 millimeters. So what we have so far is results to date. We have 6 month a composite of 3 out of 70 patients with 70.6%. One patient died due to COVID. This was really a complication, but it was during the COVID area. One patient had major amputation due to infection, but only one patient had a clinical driven TLR. So primary patency at 6 months, 78.5%, by duplex ultrasound, 81%, and freedom from major adverse limb event or perioperative death at 30 days, 100%. Freedom from male at 6 and 12 months, 6 months, 94%, 12 months, 93%. And the patients also showed improvement in Rutherford category. So just let me conclude. With regard to this reflow medical temporary spur stent system, it should reduce vessel recoil, it should increase acute luminal gain, reduce dissections, and then allows continuous flow. I say it should. We were able to see in our patients, we were treated that this is really the case. We will show you the data within the next meetings, so that you also can see how ideal this is to do an adequate vessel preparation. It preserves future treatment options and reduces the need for adjunctive therapy. And also creates, and I think this is the most important thing, adequate channels for drug delivery into the vessel wall when used with a TCP. We have promising clinical data from the TIPA Limus, TIPA out of YES, and TIPA study. Thank you for your attention.
Thank you very much, Professor Brodmann. It's a great invention with obviously promising clinical studies. The burning question will come from Dr. Jorge Ulloa from Bogota, Colombia.
Professor Glowicki, thank you very much. And Dr. Brodmann, congratulations. It is a fantastic device and a very well-designed protocol. It seems that the Limus is going to be the limousine of the future for the below-knee disease. It raises a little concern, the type of spikes that I see, but I'm sure those are micro spikes. Even though we can see it very big here, I'm pretty sure it's micro and you can barely feel it. But anyway, it reminds me of the security wires above some fences. And it raises my attention, that kind of thing, because I am sure that it's going to be useful in the terms of injecting or allowing the medication to get into the subendothelial aspect of the artery. And the presentation you mentioned that we have under the protocol, the N is 30, you achieve 23, but you present 17 that achieved the 6-month goal. Am I right?
Yeah, that's correct. 17 patients, because, you know, it was the COVID season, so COVID period, so it was difficult to include patients into the trial. So we have included 23 patients so far, but we have the follow-up of 17 patients so far with a longer-term follow-up. So we are still on the including enrollment process. With regard to the patients we are overlooking, you see the 30-day data, and you see also 6-month data from some patients. We have a good safety profile. There is also no distal embolization. There is no perforation. There was when you know, we had some fear when we do this or open this spur stent that the patients might feel pain, because you mentioned this, you know, the spikes going into the vessel wall. But there is no issue with regard to that. And our other fears were that we might not be able to bring the spur stent back out from the vessel wall, you know, and maybe not be able to retract it into the sheath. This was also not the case. So this was very, this is very exciting, very surprising. It also works in calcified lesions. The only thing you have to do in calcified lesions is to do this pre-dilatation before with an undersized balloon, so that at the end you can bring in the spur stent system. And it's really, you know, the thing we see right now that the recoil is not there, that we really can minimize the recoil. So, if you, for example, wait on the cath lab table for 15 minutes or something like this, this is the usual period, you don't see this recoil issue. And I think this is really fantastic and amazing, besides the effect that it enhances the drug uptake.
And Dr. Brodmann, you emphasize over and over again the advantages of being retrievable. Can you expand the idea a little bit more, please?
That it's ideal to retrieve because you don't want to leave something behind in the infrapopliteal artery. So this is the aspect that at the end of the day you should just deliver the drug, and only if there is a mechanical issue deploy a scaffold, and it should be then a resolvable scaffold, because we have these long vessel segments in the infrapopliteal arteries where we really do not want to leave a permanent implant behind. This is the idea behind.
Great, thank you.
Thank you very much. We're going to move on to and invite Dr. Rim El-Khoury, who is the director of ephemeral science. I believe that's probably a corporation. And she's also a vascular fellow at the University of California in San Francisco. Dr. Khoury is going to talk to us about a new device and strategy for transient balloon expandable stenting of the femoral popliteal artery, the ephemeral vascular scaffold system. Dr. Khoury, please.
Hi, good morning. Kind of in the same topic of leaving nothing behind. I'm Rim El-Khoury. I'm the science director at Ephemeral, Endovascular Surgery Fellow, and it's an honor to present work on the ephemeral vascular scaffold system, or EVSS. I have no financial disclosures. In spite of the early recognition of the ideal characteristics of a peripheral stent, the pursuit of an optimal endovascular strategy for the treatment of femoral popliteal occlusive disease has remained elusive. Balloon angioplasty and self-expanding stent often fail to fully expand the artery and ineffectively prevent recoil, new animal hyperplasia, and restenosis.
Dr. Khoury, there's a little extra sound in your presentation. Can you maybe, something is rubbing against the microphone or something?
Oh, okay.
Much better.
Now?
Much better.
Okay, great. Sorry about that. Balloon expandable stents, although they have a higher radial force, represent a more effective treatment strategy, but only short stents can be safely implanted in arteries that bend with skeletal motion, and concerns for long-term complications such as a compression and crush have limited their applicability. So the purpose of this experiment was to test the hypothesis that simultaneous implantation of a series of short resorbable balloon expandable drug-eluting scaffolds would prevent new animal hyperplasia and stenosis compared to self-expanding stents in an animal model of percutaneous femoral popliteal intervention. So the tested device, the ephemeral vascular scaffold system, or EVSS, consists of a series of discrete closed-cell balloon expandable scaffolds comprised of a copolymer of polylactic acid, or PLLA, that are coated with paclitaxel and crimped onto a single delivery balloon. The design allows for the treatment of long segments of deformable peripheral arteries with balloon expandable stents. Like a freight train negotiating a tight curve in the tracks, the scaffold remain rigid while the artery is free to bend within the inner scaffold segments. In this study, 6x60 EVSS were implanted in the iliofemoral arteries of 8 Yucatan mini swine, and a properly sized self-expanding nitinol stent was implanted in the same location in the contralateral artery. Following device deployment, the animals were serially imaged with contrast angiography and OCT. This animal model was specifically chosen for this experiment given the profound bending borne by the peripheral arteries when the animal crouches and sits. While most devices tested in this model are deployed only in the iliac artery, which bends relatively little, as demonstrated here, devices were implanted both in the iliac and femoral artery to mimic an extreme environment of bending and deformation. Chronic vascular response was measured using QVA and OCT. All EVSS were patent at all time points. 1 out of 8 self-expanding stents occluded at 90 days. Arteries treated with self-expanding stent exhibited significant and flow-limiting hyperplasia, as well in stent stenosis. In contrast, arteries treated with the EVSS only had modest vascular response and minimal stenosis. The vascular response seen in devices implanted in femoral arteries exceeded that of iliac arteries. You can see here a representative angiogram in a unique study animal. So the arteries were serially imaged. You can see that the EVSS device over time in the top row and the self-expanding stent in the bottom row. You can see the significant neointimal response to the self-expanding stent, which is familiar to all of us. In contrast, the artery treated with EVSS is widely patent, although somewhat irregular following scaffold dissolution. Maximum diameter stenosis over time measured by QVA was significantly reduced in the experimental device. So was late lumen loss. Representative OCT cross-sections of a femoral artery treated with EVSS are shown in this slide. You can see the well-opposed struts of this balloon expandable device, the modest neointimal response, as well as the complete absence of the scaffold at the 2-year time point. QVA analysis of the OCT showed, as expected, that the nitinol self-expanding stent continued to expand given its chronic outward force. There was only modest expansion of the EVSS as the animal grew over time. Mean diameter stenosis measured by OCT was significantly reduced in EVSS at all study time points, whereas stenosis exceeded 30% at 2 years after self-expanding stent placement. Mean neointimal thickness was significantly greater after permanent metallic device implantation. And this figure depicts the profound differences in vascular response between devices implanted in the femoral versus the iliac artery. Shown in red and orange, self-expanding stent implantation into the femoral artery generated a much greater vascular response compared to the iliac artery. In contrast, the EVSS generated only modest response irrespective of their anatomic location. In conclusion, the EVSS effectively reduced experimental neointimal hyperplasia and stenosis compared to self-expanding stent in this animal model, and then dissolved completely between the 1st and 2nd years. This device is currently being tested in a first-in-human clinical trial. Pre and post-revascularization acute images are depicted here after predilation and scaffold deployment. I'd like to thank Dr. Veith and the Society for the opportunity to present our data.
Thank you very much. Excellent presentation, innovative work, and very exciting stuff, really. I would like to invite Dr. Ignacio Scotto. He's a very well-known professor and chief of vascular surgery and endovascular therapies at the Hospital Médica Sur from the National University of Mexico. Professor Scotto, please, for your comments.
Thank you, Enrico, and congratulations to Professor Curie. It's a very nice research. I like this device a lot. I think it's a very interesting idea to solve this problem of the concept of leaving nothing behind in this very challenging sector of the femoral artery, which we all know that it's been always under many forces at the same time, and many devices and stents had been proved in this area with very few success. So I think your idea is going to be a very successful one for the future in their next research on patients. But I'm concerned about what will happen when this polymer of lactic acid will embolize distally. Have you been any effect on the distal arteries, especially because there will be some patients with critical limb ischemia that could suffer from embolization in this process?
You know, that's a great question. I think that the device doesn't really break down and embolize. It dissolves over time because it's a polymer of PLLA. You know, we'll have to see whether or not there's any evidence of distal embolization because of the material properties of the device. The risk of distal embolization is low.
Oh, thank you. And the images of the OCT are very impressive, and I think that's very clear, the difference between both limbs of this little swine. So congratulations, and I'm also happy to see that because of this controversy of the mortality associated to Plaquetlaxel, all these little swines are alive after the research.
They were, but a full disclosure, the device tested in this first in human trial is actually sirolimus. So
congratulations.
Thank you, Dr. Klavitsky, please.
Thank you very much. The final presentation comes from a fourth-year general surgery resident from the Division of Vascular and Endovascular Surgery, University of California in San Diego. And Dr. Rohini Patel is going to talk to us about complex abdominal aortic aneurysm repair assisted by augmented intelligence maps can reduce radiation exposure and improve safety. Dr. Patel.
Thank you. As mentioned, my name is Rohini Patel, and I'm a general surgery resident at UC San Diego. We appreciate the opportunity to present our work on augmented intelligence maps and the impact that they can have in the operating room during complex aortic repairs. We have no relevant disclosures. The use of surgical augmented intelligence is a fast developing area that was brought to our institution in June of 2019. This specific tool that I'll be talking about has been used worldwide in over 3,000 cases. Our study aim was to show how augmented intelligence and artificial intelligence software can affect patient safety and operating room staff and trainee safety as well. The 3D overlay maps, which are shown in this image, are patient-specific AI tools that are used in the operating room in conjunction with a patient CT scan and real-time fluoroscopic images. First, a preoperative map is created based off the patient's preoperative CT scan. Second, in the operating room, the previously made map is then superimposed on real-time fluoroscopic images. Third, as wires and devices are deployed and the patient's anatomy is distorted, the 3D map that's created will update in real time. And finally, there's always the option to make further adjustments to the map or even to reset it to the original preoperative map if needed. Our study was a 6-year study at a single institution, a retrospective chart review, and it included all patients who underwent a complex aortic repair from August 2015 to November of 2021. Our patients were stratified based on the use of the artificial intelligence software. Our primary outcomes included operative time, radiation exposure, fluoroscopy time, and contrast use. The secondary outcomes that we focused on were 30-day postoperative events, and then any long-term endoleak, reintervention, or all-cause mortality. Over the course of our 6-year study, there were 116 patients that were included who underwent some form of complex aortic repair. In our augmented intelligence group, there were 76 patients, which represented about 65% of our population of the cohort. And in our non-AI group, there were 40 patients, or about 35% of the cohort. What we found is when breaking it down by what specific procedure these patients underwent, the majority in both groups had a physician modified. Baseline characteristics, which included demographics and clinical risk factors, were similar between both of our groups. For our primary outcomes, we found that there was a significant decrease in radiation exposure, fluoroscopy time, and contrast use in our augmented intelligence group compared to the non-AI group. For radiation exposure, we found nearly half a reduction in radiation in our artificial intelligence group, with 1,955 milligrays compared to 3,755 in the non-AI group. Additionally, in terms of fluoroscopy time, we found a close to 30-minute reduction using the AI software, with around 55 minutes in the AI group compared to 87 minutes in the group without AI, and similar for contrast. After this, we did a linear regression model, and after adjusting for age at time of surgery, for any previous history of endovascular repair that these patients had, the aneurysm size at the time of presentation, the specific type of aneurysm as well, we found that there remained a significant decrease in radiation exposure, fluoroscopy time, contrast, and we even saw a decrease in operative time in the AI group compared to the non-AI group. For our 30-day outcomes, we found no difference in access site issues, such as hematoma, pseudoaneurysm, or embolus. And additionally, there were no differences in our groups between 30-day stroke, bowel ischemia, MI, paraplegia, or death. In terms of our long-term follow-up, we found that our group that had not used the AI software had a significantly longer length of follow-up, but we felt that that was most likely due to the fact that those patients were operated on earlier in the course of our study. Aside from that, we didn't see any difference in endoleak, reintervention, post-repair rupture, or all-cause mortality between our two groups. In conclusion, we believe that this study demonstrates that artificial intelligence software can significantly decrease radiation exposure, fluoroscopy time, and contrast use, especially in complex aortic repairs. We found no difference in short-term or long-term outcomes between our two groups, and believe that in our single institution retrospective study, that this software provides an opportunity to help with patient safety, operating room staff safety, and trainee safety as well. Thank you again for allowing us to present, and I'm happy to take any questions.
Thank you, Dr. Patel. You did a beautiful job presenting this quite convincing data. The burning question will come from Dr. Anil Hingorani from the Vascular Institute of New York, Brooklyn, New York. Anil?
So I want to congratulate the authors for this innovative, disruptive work, because I think as we do more and more complicated procedures involving endovascular work, this type of technology is going to help keep us and our patients safer. My question was more involved with some of the specifics of the radiation reduction that you were able to demonstrate and the dye reduction. Were you able to do less scintigraphic runs because you already had everything mapped out with the circles with the AI and the preoperative mapping? What exactly was reduced in the fluoroscopy? Because I suspect that it was the high intensity, high level, high frequency frames of the imaging that you were able to reduce.
Yes, thank you for your question. And correct, because the software basically can create this 3D model for us based off the initial fluoroscopic images and the CT scan, that mapping is pretty much already there. And so specifically what we found is when actually deploying stents or getting wires into vessels, that's where it was really the most crucial, because instead of having a 2D image to work off of, there is now a 3D model that made it a little bit easier to see specific angulations. So that's what we felt was the most important.
But you were able to reduce the high intensity, high frequency, high frames per second fluoroscopy with low intensity, single frame, regular fluoroscopy shots, it sounds like.
Correct. I mean, they still needed the additional ones as well, but it was overall less.
Thank you.
All right, that sounds fantastic. We have about 5 minutes to discuss all papers, and it's open for discussion. And maybe Dr. Glowicki wants to lead with one short question. or Dr. Veith, I've never seen Dr. Veith so quiet for so long.
I'd love to say something, but go ahead.
Please
Peter.
say something.
No, I have one burning comment and two questions. The burning comment is this session exceeded all my great expectations. It was great, and I really congratulate you and Peter for putting it together. These ideas were fantastic. I have a question for Dr. Patel. What your AI does is basically give you a virtual representation of the distortion created by the stiff wires and devices. That's all the AI was doing, but it's virtual. And did you validate it against what really happens? Quick answer.
Yes, it is virtual and validated in the sense that we can then determine if we're in the true lumen or not in the true lumen with wires.
Okay, but you got to be sure that what the AI is doing is what really is happening. And I worry about that. I have a quick question for Dr. Brodman. I thought your presentation, Marianne, was fantastic. It's great. Have you thought about putting the drug on the spikes and avoiding the need for a drug-eluting balloon?
As always, you have the best ideas. And yes, I guess they think of doing this and will come out with something like a spur stand with drug, so to avoid the drug-coated balloon. This will be the next step.
Dr. Baltrunas, very exciting robotic stuff, really. It's very complex. I tried to read a little bit about it, but I fell asleep because it's too complex for me. But I have a question for you. What part of the haptic typology or typology do you actually concentrate on? Is the force? Is the vibrotactile? Is the electric portion? Is the ultrasound, thermal? What exactly goes into it?
So the most difficult thing is to detect forces when the wire is moving both rotationally and longitudinally. So to detect forces on the movement is extremely difficult. So this is our patent. So we have lots of patented innovations, and this is maybe one of the most important our patents, how to mimic the forces back to the surgeon. So you just feel resistance. If the wire cannot turn into the patient, or you cannot rotate catheter, or you cannot push the catheter, the same you cannot do in your cockpit. Or you can overcome with a higher force, so the catheter will go into the patient with a higher force. If you overcome, it might kink, it might bend, but you feel everything.
So that's all non-biomimetic, right? It's not biomimetic. It's non-biomimetic, meaning is that it's not like an arm that moves. It's more like certain specific motions, and that's it, correct?
So it's like balance forces between one end and the other end. So if you feel resistance, you can overcome the force. If that force overcomes, so you feel it. So this is the idea.
Very exciting stuff.
Thank you.
I think the presentations were really great, and I also have a question to Thomas, because we are actually so excited that you can do the operation at Mayo Clinic and the patient is in Latvia or somewhere else. Is that the concept, that you can operate from the other part of the world? And what do you do if there is a complication?
So Latvia is our neighbors, so it's not very valuable. I should suggest you go for Saudi Arabia. But yes, so currently we're working on this robot, and it's interconnected with internet cable. So now it is in the other room. So we do need additional solutions, so not to have a lagging between two machines. But yes, technically the internet cable could be cut down and spread across the world. So in some future, it could be maybe even a doctor from United States and patient from Saudi Arabia or whatever country. So yes, we are going for it, but our first application for telemedicine, it will be like really populated areas like in Canada or whatever. So for stroke management, where time is very important.
I think, Peter, what Thomas is saying is that the patient is at Mayo Clinic and he's in Lithuania doing the procedure. That's what he meant. Anyway, with that, any other burning question?
I have a question, Enrico. Jean-Pierre Beckman, I don't.
Jean-Pierre, how are you?
How are you? It was an excellent meeting and congratulations. Wonderful.
Thank
I have
you.
a short question for the last speaker about the robotic. So far, I understood that it was mainly to push the wire and small stents and so on. Is there any future for larger devices like stent graft and so on?
So yes, so thanks for your question. So there is no limitations for the future development, this concept, but currently we're working on standard procedures. So no stent grafts, so everything up to 8 French. But technically, so it's not a difficult thing to update our cassette for a little bit thicker things. So for structural heart disease, for stent grafts and so on. But we are not going for it up to now because we have to have a CE and FDA certification for the most common procedures, first of all.
Well, thank you. Unfortunately, the time is up. I want to thank you all, all the presenters, the judges, Dr. Veith, Dr. Klovitsky for being here. And hopefully next year is going to be even more competitive because this is really at a level that we never expected. Dr. Klovitsky, you have the final word.
I just would like to repeat that innovation is the most powerful force of progress. And I think this is just evidence. I mean, an amazing webinar, and you guys all have great futures.
Thank you.
Be part of it.
Thank you very much. Thank you, Dr. V.
Thank you.
Thank you, everybody. Bye.
Bye-bye. Thank you.